Good afternoon, everyone. I'm Dr. Prashanth, consultant interventional pain physician at Alleviate Pain Clinics. So, welcome to this webinar on a very important topic, that is failed back surgery syndrome. So, where do we see this kind of a situation? So, the term itself is self-explanatory here. It states that a patient who was in an algorithm of care, who needs care for the condition which is the back pain. So the prevalence of back pain is quite high, and we do see a lot of patients with low back pain who require interventions in the form of, there could be simple injections, or along with that physiotherapy. That is the algorithm of care which we have as pain physicians. But today's topic deals with a scenario where they have undergone a surgery, specifically a spine surgery, and then still the pain persists. So we will be dealing with the definition of this failed back surgery syndrome and its classification, its causes, what are the possible mechanisms, why do we have such a condition, the types and the factors which aggravate, which contribute to this particular condition, and the red flags to be noted as pain physicians when we're dealing with such scenarios, and the investigations which we require, and the most importantly, the possible treatment options, what we have. Okay, so there have been a lot of trials, clinical trials, RCTs conducted amongst the pain fraternity to actually deal with such a condition and to understand the mechanism, so that a proper treatment plan is offered to the patient. So one of the studies called as the process study, they do have their own definitions. So if you see the literature, there are multiple definitions for this. Okay, so what I will be talking about is the Iasp definition for this particular condition, which states that it is a lumbar or a cervical pain, that is an anatomical, could be at the lumbar level or at the cervical level, the pain originating from that region of unknown origin, either persisting despite surgical intervention or appearing after surgical intervention, for spinal pain originally in the same topographical distribution. So as I started earlier in the beginning, that to simplify this definition, it states nothing but the fact that there has been a pain, a back pain, which could be either lumbar or cervical of origin anatomically, and for which they have intervened surgically, and now pain persists in the similar fashion, or it could be different, but the primary pain pattern still persists. Okay, so let us see now why this happens and what are the factors which cause these things. Okay, so to understand that, this particular condition has been classified based on the duration of when the pain appears. Okay, so it is classified as, it could be an acute pain, which has two categories in it. So acute, it could be within the first 48 hours of what? Of the surgery, of the intervention. So we are focusing here after the intervention. What kind of intervention, sir? Surgical intervention, a spine surgery. Okay, so a group A includes in the first 48 hours, whereas group B, it could be up to 2 weeks from the surgery, then it could be after, beyond 2 weeks. So now from 2 weeks, there is another classification where we see up to 6 weeks. and then beyond 6 months. Okay, so the classification up to 6 weeks, again after 2 weeks up to 6 weeks is classified again into C1 and C2. C1 is 2 to 6 weeks and C2 is 6 weeks to 6 months, which brings us to the last group, that wherein we see the pain after 6 months after the intervention. Okay, so in the classification we saw something called as pain which persists within 48 hours or within 2 weeks. So these are all in the category of acute pain. Okay, so that could be because of inadequate analgesia, which is providing proper pain relief in the perioperative period, or it could be because of the implant malposition. Okay, so briefly I want you to take you back a couple of slides to this particular slide where we should focus on the image. So these are the implants what you're talking about. So what are these interventions done here? So basically it is a multi-level pedicle screw fixation with laminectomy followed by fixation and fusion. Okay, so these are the implants what you're talking about. Could be the pedicle screw with the stabilizing rod. All right, so that is the implant malposition is what we are referring to. All right, it could be because, what do you mean by inadequate surgery? Here it simply goes to say that there has been, the surgery has not taken care of the primary problem, that they could not have be possible to evacuate the possible pathology completely, so which leads to that inadequacy. Okay, or it could be a surgery which has happened in a complete different level than the level which is supposed to be causing the pain in that particular patient. Or you should also keep in mind that it could be because of the vascular problems, which leading to these kind of issues, persistent issues, because we have done a surgery, but the problem is elsewhere. All right, or it could be because of the spinal cord or the nerve handling during the surgery itself, or it could be certain post-operative complications like infection. Chronic. Chronic in pain, we do classify as something which persists beyond 3 months. But in this classification, we also saw we had 2 to 6 weeks and 6 to 6 months and beyond 6 months, which do fall in that category. Okay, especially the 6 weeks and beyond 6 months do fall in the chronic category. That would be because of the residual pathology. Okay, and what pathology are we talking about over here? We will see in the slides, in the upcoming slides. So the recurrent, it could be residual or recurrent. Recurrent, you see in 15% of the discectomy cases, which have the added foraminal stenosis, or it could be because of the inadequate evaluation, after which there was a algorithm of care planned. But definitely, if the evaluation is inadequate, then the plan would not take care of the actual pathology completely. It could be a mismatch, a different sort of complication at the evaluation level. All right, it could be, as I mentioned, the complications, or it could be purely because of the technical failure. So what are the causes of chronic pain in FBSS? That is a failed back surgery syndrome. All right, so discogenic pain. So this is the pain which is arising from the disc. So just to give you a broad idea, so we have the model of the spine over here, where we have the bones, the vertebra. Okay, so in between the vertebral bones, we have this soft structure, which is nothing but the intervertebral discs. So the pain originating per se from the discs is nothing but the discogenic pain, or it could be because of the recurrent disc pathology, again, implant related, could be an infection of the disc, which is termed as discitis, something called as unmasking pain, wherein there will be a dominating pain generator in the primary setting, and once the primary pathology has been taken care of, certain secondary pain generators become dominant, and this is nothing but the unmasking pain. And now most important of all could be facetal arthritis. So just to as a recap, spoke about the prevalence of low back pain. So low back pain can be multifactorial. So among one of the factors is the facet joint. So now where is this facet joint? Okay, so as we showed the disc, so similarly between the two vertebral bones, we have this small joint in between, right? On either side, at one level we have two facetal joints joining the two vertebra. Okay, so these are nothing but the facet joints over here. Okay, so there could be a component of facetal arthritis, or it could be because of muscle spasm, and also could be an added trigger point which can appear post-operatively, or it could have appeared as something new in that particular patient. All right. So SI joint strain. Now, these are something called as mechanical causes of pain post such surgical interventions. So what happens is, as you saw in earlier picture, there was a fixation, multi-level pedicle screw fixation, and then when that happens, there is a loss of lordosis. Okay, so there is a mechanical instability which is happening over here, which is finally communicated to the SI joint, the sacroiliac joint. So there is a mechanical issue which happens post such fixation and fixation surgeries, multi-level fixation surgeries, which can put a lot of strain onto this SI joint. Definitely can present bilaterally or unilaterally. So that could be another added feature which causes such persistent pain in patients who have undergone spine surgery. So what we see is spine surgery is not a simple surgery. So it can cause a lot of mechanical issues, instability issues in the spine. So coming to recurrent stenosis. So as you know, whenever there's a discectomy, for example, it is impossible to remove the complete pathology, right? So what happens is, again, a part of the disc which goes and occludes this the foramina, and then the patient at the same level, the patient will have the similar kind of pain, and the patient per se will think that the primary problem has not been taken care of, whereas it could be because of recurrent stenosis, or again can lead to mechanical issues like kyphoscoliosis post surgery, or it could be a stress fracture of the facet joint or the vertebral body. It basically goes to say that any fracture of the bony parts in and around where the surgery has been performed, or more importantly, even the bone grafts which have been kept, there could be a stress fracture in them which can cause this post-operative pain, which persists for more than 3 months, more than even 6 months. So this is what I was talking about, the mechanical spine changes which happen after the surgery, or especially after the post-fusion or instrumentation, and then certain other post-operative changes which can happen like the fibrosis or the scarring. So you can see, even if there's a wound on the skin, there's a cut wound, it rarely heals in a fashion that where you can know that okay, it's completely healed. What I'm trying to say is there'll be a scar which reminds you of that particular injury, right? So which then it can happen on the skin. Similar things can happen even at the places where the surgery has been done. So not only on the skin, but on the underlying tissues very close to the spine, okay, which can cause entrapments of the nerves and causing radicular pain, which is a nerve related pain shooting down to the legs from the back, or it could be simply because of a sympathetic reaction. What is it reacting to is the instrumentation or the surgery which has happened on the spine. And then any pain which persists for months together definitely has a lot of effect on the psychological profile of the patient. And here you can imagine a patient who has undergone a major surgery, thinking that that would provide the kind of relief which was expected. So here the expectation level also matters. So that all goes to say how the patient had been dealt with the perioperative counseling and what has been explained to them, and whether the expectations have been reached or not. Based on this, they play a big role in patients who present with pain post surgery, especially a spine surgery, major surgery like spine surgery. Okay, so certain concepts which would explain why such do we see such scenarios post surgery. Like in case of if it was a nerve root decompression or a discectomy and a fusion has been done, whereas the problem is much more lateral, which is nothing but like a foraminal stenosis. So where there is an inadequate decompression at the lateral canal, that could be because of the anatomical factors, or it could be the degree of problem which is seen in the perioperative phase. Okay, so now we have something called a spinal stenosis. Okay, that spinal stenosis will come in we'll see in the future slides what are the causes of spinal stenosis. But this is not a standalone condition. Along with it, if there was low grade spondylolisthesis. Now, what is the spondylolisthesis? So, listhesis is nothing but translation of the vertebrae over each other. Okay, so they should be in this particular fashion. If at all there is some fracture, especially in the pars interarticularis fracture, what happens is one particular vertebrae will slide over the other. Okay, so there will be a step deformity on evaluation. So if they have two concurrent conditions and only one particular condition has been treated, then definitely there will be persisting pain. So in complete evaluation, the pathology which was causing the pain has not been dealt with, and the primary reason for that would be in pain practice, especially dealing with low back pain. The dictum is don't treat the MRI, okay? Because even in an asymptomatic patient, if you do take an MRI, we will find numerous findings. Okay, so it is only important to treat the particular pain pattern the patient presents with, and correlating that with the imaging studies and the features what we find in those imaging studies like MRI, for which the following points are very important, like history and clinical examination, and then that is when that is supported by imaging studies like MRI, then we can come to the proper conclusion as to as which is the particular pain generator, which can be a simple single pain generator, or it could be multiple pain generators. And also evaluation in pain is never complete without evaluating the psychological profile of the patient. As we know that they also can the psychological health of the patient can alter the treatment, and also has a big bearing on the result of the treatment which he or she is being offered, be it in any algorithm of care. It could be surgical or non-surgical, like what we do in a pain practice. So we did see that in the classification there could be immediate pain within 24 hours, within 2 weeks. So what are these due to? It could be because of complications like the infection like arachnoiditis or an incidental neurotomy which leads to a pseudomeningocele, which is the bulge what you're seeing in MRI, or it could be because of the misplaced pedicle screws. Okay, these are the immediate causes. And for later causes, again, it could be because of the facet or a pedicle fracture, or the collapse of the bone graft, or a surgery at the wrong level. So this is what we meant by the pedicle screw failure, fixation failure. So what has happened, as you can see that the track of the pedicle screw is seen over here, and it's just misplaced from its position. Okay, this can lead to a lot of mechanical issues over there, and the decompression which would have been offered otherwise is not there, leading to pain, persisting pain, or something, some neo pain picture in this kind of patients. So another dictum is whenever you have pain at particular anatomical origin, do examine and do focus on a joint above and below that point. Okay, because there's a lot of referred pain patterns what we see. Okay, so that is what we mean by the extraspinal pathology. Could be because of the primary hip disorders like osteoarthritis of the hip or the osteonecrosis of the head of the femur, or it could be something like the GTPS, that is the greater trochanteric pain syndromes. Could be other nerve injuries, peripheral nerve injuries, or their entrapment, or it could be something called as piriformis syndrome, wherein you have a shooting pain, sciatica like pain, which is very similar. The patient presents and they often tell us that I do have that sciatic pain, which shoots down from my buttocks or the low back onto my legs. So this is a kind of pain where you have low back pain with leg pain. That classification is also important. So all goes to say that the importance of talking to the patient and the clinical evaluation which is needed when the patient presents primarily or with a condition like what we are dealing with today, like the post-surgical pain syndrome. Whatever be it, we have to treat them like new patients so that you evaluate from scratch to come to the pain generator, and then obviously you can treat that. It can be because of sacral fractures, ischial bursitis, gluteal tendinitis, or the hamstring syndrome. So a little bit of the osteoarthritis of the hip. So as you can see in an X-ray, the irregular bone pattern, the loss of the smoothness of the head of the femur, which is commonly seen in elderly with spinal stenosis. So these are concurrent conditions wherein we can miss these things and primarily focus only on the MRI of the low back. And as I said, there could be a lot of findings which may not be the actual pain generators. So in osteoarthritis, you have the patient could be having a limp, and then it could be presenting with groin pain. And when you examine, there will be limited internal rotation of the hip. When you ask the patient, could be history of dislocation, alcohol abuse, or the very important corticosteroid abuse, which can predispose to these conditions. And a simple X-ray, weight-bearing X-ray and AP view will help you rule out these conditions. Coming to the GTPS, that is the greater trochanteric pain syndrome, wherein the pain is in the proximal lateral thigh, radiating to the distal thigh below knee, increased by lying on the same side, climbing stairs, and sitting to standing. So you can see here, as a practicing pain physician, it is so similar to other conditions, the aggravating or the relieving factors. So it is all the more important to explore all the differential diagnosis when it comes to low back pain. So basically involves the bursa, the external rotator tendons, or could be with the iliotibial band. Okay. And when you examine, there will be tenderness at this particular point at the lateral aspect over the greater trochanter. A simple diagnostic injection also could be done to rule it out. Could be nerve entrapment like the lateral femoral cutaneous nerve, the peroneal nerve, the sciatic nerve. Again, nerve related, we go ahead with the nerve conduction studies, and it could be again a diagnostic test can be performed. We just spoke about piriformis syndrome, where a tight piriformis muscle presses against the sciatic nerve, irritating it, and thus causing that pain which travels all the way down from your glutes all the way down to the leg, which is nothing but the topography of the sciatic nerve, where the compression at the proximal level causing the shooting pain. So, which is very similar to the disc pain, a radicular pain, which is nothing but the compression of the nerve root by the disc. So again, we have to rule it out. So, lateral canal stenosis. So what I'm talking about on these slides are nothing but the various conditions which cause a similar picture and which could have been missed out. Okay. So the lateral canal stenosis is, the prevalence is 2 to 29% of the FPSS patients, pain predominantly in the leg or the buttock region. Okay. So lateral canal, so it is more of a radicular pain, often involving the single dermatome, seen in standing and walking. All right. So a simple transforaminal block can provide a longer relief when you add corticosteroids along with it. So coming to the discogenic pain. So as I told, it is the pain which is arising within the disc. So the normal disc does have a annulus fibrosis and the nucleus pulposus inside. Okay, as you can see that there's a lot of neovascularization. So when there is neovascularization, there's obviously the chemical soup, the inflammatory soup, which is going to be accumulated in that area. Sorry, I'm not going to see the marker. All right. Okay. So how do they present? It will be like a midline vague diffuse pain, which could radiate to the gluteal regions, which is very important, significant factor here. It is non-dermatable. It's a diffuse kind of pain. Okay. And important aggravating and relieving factors like aggravates on sitting to standing, especially in the flexion of the spine. And when you examine, you could be having the midline tenderness. Okay. Disc herniation, commonest diagnosis for back pain and radicular pain. So for which most of the surgeries are performed, but as we saw, if they do have the other concurrent conditions which you just saw in the previous slides, again that would be coming into the category of a failed back surgery syndrome. That doesn't mean the surgery is a failure. Okay, does that it's not been the pathology has not been taken care of completely, or it could be having other concurrent pathologies. Okay, so the whole point of this topic today is to focus the focus is on the fact that every DD, differential diagnosis, has to be explored thoroughly so that we do not land up in such a scenario. Okay, so 7 to 12% prevalence. It could be radicular, that is a dermatomal shooting pain down the leg, or it could be simply a midline axial pain. Okay, again, do MRI too, could be a recurrent herniation or the residual pathology after surgery. So another very important condition, as I told you, the the facet joint. So it is a synovial type of a joint which has a synovial fluid and a capsule of its own. All right, it is supplied by its nerves, medial branches of the spinal nerves. If this pain is there, it has its own pattern. What pattern is that? It could be unilateral or bilateral. There could be tenderness on the paraspinal tenderness will be there, and then features like pain on side bending and extension of the spine. Okay, relieved by flexion. The radiation, again, that is more of an overlap over here. The radiation could be from the low back, all of the glutes, but it rarely crosses the knee joint. It could be radiating down the thighs onto the the back of the thighs up to the knee, rarely crossing the knee joint. Okay. So imaging studies will rule it out along with your clinical examination and the history told by the patient. So the SI joint, there could be a primary pathology of the SI joint, or as I told earlier, could be because of the mechanical stress following the spine surgery, which can cause a sacroiliac joint strain, leading to persisting pain later on. It will be seen in 2 to 3% of the FBSS patients. And as I said, because of mechanical changes, pain will be very classical. As you can see in this picture, the patient is holding onto the paraspinal area, which is actually over the PSIS. Okay, distal to the posterior iliac crest, lateral to the midline spine. So again, this can be referred to the groin. All right. Again, aggravating factor is sitting to standing. Again, these are classic points. It doesn't mean that every SI joint strain or pain presents in such a manner. All right. You can rule out with an MRI with an SI joint screening, and a simple SI joint injection, diagnostic injection can rule it out, and then you could also make it a therapeutic injection. This is the Faber test being performed to evaluate the SI joint pain. Again, SI joint pain cannot be, ruled out or ruled in just by doing one particular test. It has to be a combination of at least 2 to 3 tests clinically to come to a diagnosis. So spinal stenosis and axial low back pain. All right. So what is the spinal stenosis? See, as you can see over here, this is the disc and this is the spinal cord. So if there is any compression in the central portion by the disc, then it's the spinal stenosis in the central canal. Okay. But here you're seeing the disc portion, which is far lateral from the midline, compressing onto the nerves. So this is the lateral canal stenosis. All right. So neurogenic claudication, another important factor wherein the patient presents with the axial pain, and then there's a shooting pain or numbness, paresthesia and numbness traveling onto both the legs, and classically which is relieved by forward bending. Okay, so that is a clincher for the spinal canal stenosis. Okay, so this can develop post surgery at the levels adjacent to the surgical levels. Okay, this is again a post-operative complication, which is epidural fibrosis, where you can see that post-surgical in the post-surgical area there's a scar tissue which is encompassing the nerve root over here. So again, definitely it can cause a radicular kind of pain. Okay, which is persisting in the patient. So again, it comes into the category of failed back surgery syndrome. Again, can be taken care with the help of adhesive lysis. Okay. So another important contributing factor is termed as deconditioning. Now, what is this deconditioning? So this is more of the myofascial component over here, wherein post-surgery, post such major surgeries, and during the rehabs, when we see that the muscle has lost its strength and endurance. What muscles? We're talking about the core muscles, which is in the paraspinal area. And that is due to the reduced activity, impairment, and disability. And this could be also because the fact that we all know that low back pain can be very painful. Even in the NRS scale, when we log in and ask the patient to log in the score, you know that they can have very severe pain. So even post-operatively, they feel that if I do this particular activity, which was causing the pain, which it can again might cause that severe pain, and the patient doesn't want to go through such a scenario again. So ultimately leading to reduced activity, impairment, and disability, causing deconditioning. Okay. So now this is nothing but pathologically or microscopic level. If you see, there is decreased cross-sectional area of the muscles, and which is a biomechanical strain. Okay, with the loss of density and strength. All right. So you need to have this rehab more focuses more than physical rehabilitation. It is rehabilitation at the cognitive level. They may even requiring the CBT kind of treatments, which has to help them to bring them out of that fear and to be having that confidence that to go on with their day-to-day activity, so that there is a reversal of this deconditioning. So along with that, we have to focus on their coping abilities. There is a study which states that there is an incidence of child abuse also predisposing to such conditions, which goes to say that proving again the biopsychosocial model of chronic pain, stating that such pain is not only structural, wherein we go in search of any structural problem which was leading to the primary pain and also to the persisting pain after surgery. And you can see that in pain after surgery, the psychological factors have a bigger impact. Okay, so it's always a combination of the biopsychosocial aspect leading to the persistence of such painful conditions leading to chronic pain. So this is just a summary of whatever we spoke about so far, like the importance of history taking and finding out whether it was a preoperative versus the current pain. So it's like you have to see whether it is similar to the preoperative pain and the current pain. Then goes to say that every patient you have to treat it as a new patient and evaluate, and then see whether it is similar to the preoperative pain or is there something new. Okay, and location, of course, whether it is purely the low back pain or the leg pain or low back pain with leg pain, and response to mechanical changes. This is nothing but evaluating the aggravating and relieving factors and the quality of pain. Again, whether you need to know whether it's a nociceptive pain or a neuropathic pain. Excuse me. So again, with the history taking, we do come to know whether it's there since days to months. With was there any partial pain relief, or there is something new like a leg pain or low back pain, which is we need to know whether it's improved or but recurred or improved recurs but it is different. So this goes to say whether it's a multi-level or at that level. All the things which we spoke about, the mismatch, the wrong level, or the complications, and if there is anything new factors contributing. So all these things have to be kept in mind. So initially I told we'll discuss about these red flags. So what are these red flags? It's a very important slide. As a practicing pain physician, not only forget about today's topic, red flags anywhere. We do come across different red flags when we deal with each particular anatomical area in the patient. So today we'll be dealing with of course, we're talking about the spine. So any leg weakness with paresthesia post-surgery, any bladder or bowel incontinence or dysfunction which tells you about the significant canal stenosis with the Claudication syndrome. So any other constitutional symptoms like weight loss, low-grade fever, okay, any nocturnal pain, these has to be evaluated, and accordingly you have to find evidence with the investigations, or if it is an on an emergency basis, you do have to refer to other practitioners or the other specialties, respective specialties. So can we now we come to the investigations. So a thorough investigation is required, as you can see, with complete blood picture, with ESR, rule out any inflammation, infection, MRI, CT scan, X-rays, diagnostic injections, discography, okay, wherein, as you can see over here, so a dye has been injected. Again, discography plays a big role in evaluating discogenic pain. So at the same level and one level up and one level below, risk will be evaluated, wherein the injection pressures are monitored, and at what injection pressure does the patient have the concordant pain, meaning to say the similar pain which he had, we are trying to kind of simulate it in the OT room or the procedure room by injecting this dye, and trying to see that whether that disc is the reason for the pain, persisting pain. Again, it's a very complex procedure and with its own limitations and complications. So with all these things in mind, it has to be, we should go ahead with the proper counseling of the patient, and any nerve related or muscle related can go ahead with the electromyogram. So broadly speaking, we can start off with the conservative treatment, which includes rest, medication, and physiotherapy. If not, then progress to the interventional modalities of treatment. Even in the interventional, you can later on think about advanced interventions like the spinal cord stimulator and intrathecal pump, or maybe they do require surgery. So here there's a saying that failure of surgery doesn't mean the success of this non-surgical treatment, or the failure of non-surgical treatment doesn't mean that the surgery will be successful. Okay, so it all goes hand in hand. Finally, we are here to provide pain relief and take care of the patient per se. So non-specific modalities include the rehabilitation, which includes counseling, could be TENS, IFT, intramuscular stimulation, or the physical therapy. And most important of that, again, you have to contribute, you have to add cognitive behavior therapy, which, because the psychosomatic symptoms, they're a big brunt on this particular condition, finally leading to the functional restoration. So the functional status up to which the patient wants to be restored has to be evaluated before you, as you're talking to the patient the first time. So based on that, you can plan your rehab protocol, including the strength training, and this overall leads to 10 to 50% pain reduction. Then of course you have to supplement it with the pharmacotherapy, includes the analgesics and the adjuvants. Analgesics like paracetamol, non-steroidal anti-inflammatory drugs, adjuvants like the muscle relaxants, antidepressants, and anticonvulsants, which play a big role in finally providing the pain relief and maintaining the pain relief in the patient. So coming to now we know, once there's a failure of these non-interventional modalities, we go ahead with the interventional therapy, which could be a simple epidural steroid injection. More oftenly, we have to rely on the transforaminal, because you know that in surgery, as you can see, the laminas are missing. So there's a laminectomy. So and then we need to go ahead with this transforaminal injections. Or if facet is a problem, you can go ahead with the facet joint injection, diagnostic facet joint injections, and then once you know that they are successful, you can definitely opt for the radiofrequency ablation of the medial branch, supplying the facet joints. Like joint injections can be performed fluoroscopically, or nowadays we do the bimodal kind of treatment where you use the ultrasound as well. So you can do it primarily ultrasound or combine both techniques to do the particular SI joint injections. And then we did see that there's adhesions, the fibrosis, which can cause this kind of pain which persists for a longer duration in post-spine surgery. That can be dealt with the epidermoplasty, wherein you're targeting, the principle is to target the adhesions which are present around the nerves. Okay, so which is accessed through the caudal space, wherein you pass the catheter and the lax catheter, and we do inject medications which will cause adhesiolysis of those adhesions. Again, the due risks should be explained to the patient, counseled properly before doing this. and also be evaluated thoroughly after the procedure. Spinal cord stimulation. Today's topic, FBSS. Okay, a lot of studies have been done on this, and then for this is nothing but a recurrent persistent pain, neuropathic pain, post-surgery, spine surgery. This particular intervention, that is spinal cord stimulation, has been proved to be quite effective in such resistant pain conditions, neuropathic pain conditions, especially post-spine surgery. Okay, it works on the gate control theory, wherein the painful sensations is replaced by sensations like vibration feelings or sensations in the patient, wherein where you place the electrode is placed in the epidural space. Again, there has to be a trial which is done before placing the permanent leads. In the temporary leads, we do the trial to determine which area has to be in the epidural space. The stimulator has to be placed. Okay, so after the successful trial, the permanent leads are placed, providing the pain relief through the gate control theory. You could also intervene with an intrathecal pump with morphine, clonidine, and baclofen, which also release the muscle spasm, recurrent spasms, or the resistant spasms. You can use the baclofen in the intrathecal pump. Again, these are very advanced interventional spine procedures, so it has to be done after a proper trial, and which has its own cost, and also all these things have to be counseled to the patient with the due risks and the benefits as well to take a call. Thank you. So
thank you, doctor.
All right. Any queries, you can do contact Alleviate Pain Clinics. We are there. In any of your friends, relatives with a similar condition, you can do contact them, and we'll definitely have a look and try to be helpful as much as possible. Thank you.
Thank you, doctor.